everyone. It's 12:15, so we'd like to go ahead and get started. This is Mark East with the State Medical Association. And as we get started here, I just want to go over a couple housekeeping things. We are going to try to keep the phone lines open so that way you can ask questions. However, if we're picking up a considerable amount of background noise, I'll just go through and I'll mute the lines. We'll open them up later on in the call. You have a mute option on your phone. We certainly encourage you to do that to try to prevent any background noise. With that, Stacy, I'll ask you to introduce our speaker for today.
Good afternoon, everyone. As Mark said, my name is Stacy Fredenberg, and I'm the Communications Manager for the South Dakota Foundation for Medical Care. We're part of Great Plains Quality Innovation Network, and we're excited to be partnering with the South Dakota State Medical Association on a 10-part series of webinar briefs. Key centered care topics will be presented in 15 to 20-minute webinar segments, highlighting provider and clinician perspectives while introducing corresponding resources and tools. Today's webinar, Tools and Resources to Promote Self-Management, will focus on engaging the patient beyond the exam room. With best intentions, many patients struggle to make the necessary lifestyle changes to manage chronic health conditions. Response to community-based programs can improve health outcomes for patients by teaching them to set goals, establish accountability, and track progress. We'll introduce our speaker, Eric Johnson. Dr. Johnson is an associate professor in the Department of Family and Community Medicine and Education Resources at the University of North Dakota School of Medicine and Health Sciences, where he is the Director of Interprofessional Education and Medical Director for the Physician Assistant Program. Johnson is a graduate of the University of Nebraska-Kearney with a BS in Psychology and the University of Nebraska Medical Center, where he received his MD in 1989. Completing a residency in family medicine at the University of North Dakota Fargo program, Dr. Johnson is board certified in family medicine. He is current president of the American Diabetes Association, North Dakota affiliate, and president of Tobacco Free North Dakota. Thank you, Dr. Johnson, for sharing your knowledge and expertise with us today. Go ahead and begin your presentation.
Thank you very much for that fine introduction. As the listeners probably know, I was on a couple of weeks ago. We talked about some different things to help patients set realistic goals. That had to do with motivational interviewing, and we also touched upon some key guideline-based principles from the American Diabetes Association Standards of Care. As you'll recall, there's a big push now for more psychosocial aspects of care, as well as getting patients connected to appropriate community-based resources outside the walls of the clinic. We'll expand on that particular portion of this a little bit today. I'll be happy to take questions. If you want to reach out to me via email, I can certainly visit with you that way as well. So we'll start our tools and resources to promote self-management. These are closures. They are to identify the provider role for patient self-management and about utilizing community-based tools and resources for referral. How does this exactly affect our patients? Often, despite best intentions, many patients struggle to make the necessary lifestyle changes to manage their chronic health conditions. Actually, a big push right now in schools as well for more appropriate chronic disease teaching, so the students and residents can actually have more first-hand exposure to managing chronic conditions over time and have a focus on more episodic care. And some of that has to do with electronic health record as well, population management tools, etc. We also think about referrals to community or other based programs to improve health outcomes for patients, getting them to set goals. Accountability is very important. This means increased frequency of contact, which doesn't necessarily mean more clinic visits. And talk about ways that we can do that. It's important for us to track progress. We don't want to just be increasing frequency and giving patients more and more information. We want them to be able to use that and show outcomes that make sense to them. making necessary lifestyle changes. In our previous discussion, we talked about overcoming some barriers using tools like motivational interviewing, really helping the patient manage their life circumstances as a context for change. Quite often when I see patients with diabetes in our diabetes clinic who are struggling, they have some life issue that may be interfering with their ability to optimize their own self-management. And can help them approach some of these things. It can be something like, in a relationship or a change in a job, or something is happening with one of their children. Lots of things that might diabetes or their chronic disease management really off of their list altogether. And then they lose some time and have to make that up. Although we may facilitate this as providers, see patients 2 to 4 times a year in clinic would really not be enough to help patients establish accountability necessary to really make a change with their chronic disease treatment. So I'm going to share about some of the things that we can do to make these referrals, helping identify resources in your community or your area, and not only formal community-based programs, but some feature on what a healthy community and knowing the resources that are available to you in your community. A couple of key recommendations that come from the American Diabetes Association Standards of Care. There has been a big push, a big conversation with ADA about psychosocial aspects and management of diabetes. They've had a recent position paper on this. There's much more explicit language now in the headline document. I would encourage you to look at, if you just Google American Diabetes Association Standards of Care 17, it'll pull up the full document for you on the January issue of the journal Diabetes Care. Well, you'll see an alternate link for a primary care version of those standards of care. I'm on a committee for ADA that creates that, the Primary Care Advisory Group, where we take the giant 180-page document and crush it down to about 20 pages. So you can see some of these guideline-based pieces and apply them to your own practice. So treatment decisions that should be timely and based on evidence-based guidelines, but tailor those to patients' preferences, prognosis, and comorbidities, as well as their abilities. So we're just not going to be able to manage a more complex program very well. May be able to be plugged into some kind of community resource that would be very helpful to them. And should always consider the burden of treatment and self-efficacy of patients. We are recommending treatment. Diabetes and prediabetes in the United States. About 30 million people currently have diabetes in the United States. 90% of those cases are type 2. And everyone on this call, of course, is well aware of the increase in type 2 diabetes over the last decade or so, corresponding with an increase in obesity, which is a significant risk factor. About 6 million people have the high-risk condition prediabetes in the United States, and these patients have an extremely high risk for going on to develop type 2 diabetes. This is thought to be anywhere from 15 to 30% over 5 years with no intervention. With prediabetes, don't know that they have it. If they do, they don't attach a lot of significance to it. They aren't getting the appropriate information about what this means. But this is really a critical time to make an intervention. Lifestyle interventions have a huge impact on those with prediabetes conditions. Once they convert to type 2 diabetes, it's going to be very difficult to achieve goals without medication. But lifestyle management can make a big difference in reducing the conversion of prediabetes to type 2 diabetes. And community-based programs, really evidence-based in this regard, and we'll talk a little bit more about that. But unchecked, this could lead to as many as 1 in 3 adults having diabetes by 2050. That's going to be an incredible impact on our healthcare system. It's probably not sustainable. I think that right now in 2017 dollars, that persons with diabetes spend about $12,000 a year on health care. At the same age without diabetes spend about $2,000 a year. You can see that this will exponentially place burdens on our healthcare system. The team care elements are still very important. Diabetes centers have physician or nurse practitioner or PA providers for all of those, certified diabetes educators or nurse educators, and registered dietitians, among other important professionals. But resources that are available to you, and be sure that you're using them. I'm amazed when I go to a community that has a certified diabetes educator and a licensed registered dietitian, and those two tell me that their schedules aren't full, or they're not that busy, or they think they could be doing more. So be sure to use the appropriate resources. I find that to be very helpful in my practice because it helps relieve some time burden for me. If I get a patient plugged into all the other appropriate resources, their care is going to be complete, it's the standard of care, and at the same time, it really promotes efficiency for all of us. You know the guideline-based cares, the National Diabetes Education Program, American Diabetes Association, National Diabetes Prevention Program, CD, American Association of Clinical Endocrinology. All of these have excellent tools for use. I think in primary care, a lot of people rely on the ADA document. All of these are good. Electronic health record tools can be critical. As we have grown into our electronic health record over the last 7 years here at our healthcare system, more tools that help us do this, particularly with some population management pieces. Right now, if I wanted to, I could reach out to everybody in my practice with an A1C over 9, for example. Use some medical home and nurse-driven follow-up. This in with what I was talking about, increasing the frequency of contact, but necessarily the frequency of visits. To reach patients outside of the clinic and healthcare system and help connecting them to available resources that are going to improve their outcomes and give them some confidence and have them get some buy-in into their own care. You may be familiar with the Wagner chronic care model. This is a 6-component model that looks at delivery system design, management support, which I think we all understand is a critical piece in diabetes care, decision support for the provider, information systems that help us connect to other providers, other systems, community resources and policies, and also a piece called health system science. As I mentioned earlier, there's a lot of development in medical school curriculum to address the Wagner model for education. And I'm on a committee with AMA right now working on this, and that's a very exciting piece. Also think about lifestyle management for type 2 diabetes in this context. The American Diabetes Association is very explicit about lifestyle management in type 2 diabetes. To diabetes self-management education and support. Nutrition therapy is evidence-based to show that that can lower A1Cs up to 2%. Guidelines for physical activity and weight loss as for prediabetes. So do convert, they cross that magical statistical breakpoint into type 2 diabetes. Lifestyle is still going to help them. It's unlikely that lifestyle alone will manage their problem, although occasionally we see some patient success stories with this. But when they convert to type 2 diabetes, they have a lot of other pathophysiology that's driving that. But style is still important in this particular setting. And I also want to put a plug in for adults with type 1. I think of type 1 as a kid disease. There's actually more adults with type 1 diabetes in the United States now than children. Like a lot of Americans, adults with type 1 sometimes struggle with lifestyle issues as well, including obesity. So we don't want to forget about those patients either. The real focus, though, on lifestyle management for prediabetes, and this is going to lead us into our conversation, connecting with community resources. we need to think about diabetes prevention in those at risk, which are the ones that we think of on the pre-diabetes spectrum. It's the research really points to 150 minutes a week of moderate physical activity and a 7% weight loss with calorie-deficient diet to really help people lose weight. The Diabetes Prevention Program Research Group published their first paper in 2002 on this. A particular paper and many programs that are based on these principles, with this can reduce conversion of prediabetes to type 2 diabetes by 58%. Recently presented this information to a patient group in Minot, and a lot of them had never heard of this, which surprised me. They were also very surprised that over half of them, if they undertake a program like this, would significantly reduce or delay their conversion to type 2 diabetes. Lifestyle interventions often improve other chronic disease conditions, of course, weight management, but we also see some real gains with hypertension. And we also see some gains with some psychological components that can go along with these patients, like depression or anxiety. So these types of prevention programs really very holistic and can be very useful for patients. Clinic models, the TASTE care for chronic disease management with appropriate tools and guidelines is very beneficial. And places are doing this now, and I see this more and more all the time, even in smaller markets. We really need to support patients more out in the community to keep them engaged and improve accountability and talk a little bit now about community-based resources now that we've kind of, lay of the land for those with type 2 diabetes and pre-diabetes syndromes, and what the current state of care is, and what we can do to take that and connect it to community-based resources. This prevention program, which you can find on the CDC website quite easily, has a number of sub-tabs here that you can see on a cut picture of the website. You can print curriculum requirements if you're going to start a program like this, or what these programs have for curriculum. Would choose a CDC curriculum program, as well as lots of other handouts, both in English and in Spanish. So this is kind of a one-stop place for you to learn more about the National Diabetes Prevention Program. And if you're interested in starting one of these programs, all of your resources here to get started are available too. I want to think about what CDC recognized means. And of course, this means that it meets quality standards. And there's a lot to do with creating programs that are consistent with some of these original studies in diabetes prevention. It also should have a program that can track results and demonstrate outcomes. Since this is so science-based, my experience is that most places that do this are getting the outcomes that they want and buy-in from the community. I think that the buy-in from the community is a really important piece of this. Point of view, what kind of messages should we be sharing with them to get started? Well, I want them to have some immediacy about what's going on with them. Diabetes is a fairly significant condition. We already have elevated cardiovascular risk in the prediabetes state. You have to convert to type 2 to already have an increase in risk. It's about 1.3 to 1.5 times higher than those with normal glycemia. And there's those who convert to type 2, we usually think of them as having risk 2 to 4 times higher. There's lots of good screening tools for patients to assess their own risk with prediabetes and type 2 diabetes, with online quizzes that are available on the CDC website. The Diabetes Association has a similar risk tool on their site as well. And the message through these screening tools is that if you are high risk, you want to talk to a healthcare professional about being properly evaluated and classified, so get you into the right program, right resources, etc. And have prediabetes, join a CDC-recognized lifestyle change program or something similar that might be not only offered in the community, but at maybe a healthcare center in your community as well. want to find lifestyle change programs that work for individual patients. Assessing what they might want to be doing for more exercise and activity. Telling some people to walk more is not a good option. They have something that's keeping them from doing that, like osteoarthritis. Big focus on helping people find activities that are useful for them. An example of the CDC online screening test for patients. This is easy to find on the CDC website under the National Diabetes Prevention Program. It just gives a little discussion, a little bit of a definition of what prediabetes is. It has a standardized quiz that you can take, and then it gives you a score to assess your risk. So this is very easy for patients to use. This is something that we'll try to send out like through social media or other outlets, because we know that we don't necessarily need to have patients in the office to take this quiz, although we can certainly administer it there as well. Community-based programs is also very easy on the CDC website. As you see here, I've posted the list of South Dakota community-based programs and Dakota community-based programs. You go to the website and you click on the community, it actually brings up all the contact information that you need. Community-based programs, to go back, these are the ones that meet CDC standards and guidelines, and they're certified as a diabetes prevention program site. There are many other program sources that we should be thinking about. Many healthcare systems have weight management or diabetes prevention programs. Here, our healthcare system at Altura and Grand Forks, we have a really strong medical weight loss program, which of course we see a lot of success in those who are at risk for developing type 2 diabetes, pre-diabetes spectrum. But the program really is focused on medical weight loss, and that just kind of comes along for the ride. We've had so many patients go through medical weight loss, we no longer have a surgical weight loss program here. We're referring those out because we have fewer and fewer all the time. And many other healthcare systems have similar programs to this. I can think of a number of communities in North Dakota where the healthcare system has a program, but it have this blend of community-based resources and healthcare system-based resources. So the patient can find the one that's best for them, that maybe meets for some other issues with them like finances. Third-party payers offer benefit, and some employers offer benefit. For example, I'm an employee of the state of North Dakota. I work for the School of Medicine and Health Sciences. A third-party payer for our insurance as employees, in conjunction with the university, offers a lot of lifestyle management programs. They have in-house tobacco cessation program. So knowing what resources are available to your patients and in the community is very helpful. Now, sometimes so many of these we can hardly keep track of them, particularly with third-party payers. But I encourage patients, check with insurance provider and see if they have something like this. Sometimes it's as simple as a small rebate for joining a fitness facility and a certain number of times per month. That promotes accountability, that promotes success. Something as simple as that can help a patient. Success in any program really relies on frequent visits and contacts with patients. Most of these community-based programs contact 16 times a year out of the program or a number in that range. And if we do that and have frequent contact with these patients, they don't get away from us for a few months, kind of get away from what they're doing, get too busy with their life and kind of forget about keeping some of these things prioritized. This can be phone contact, this can be electronic messaging. It can be more frequent contact maybe with a community program or a health system program. So really, any of these things to improve frequency of visits can be very useful. I want you to think about what else is in your community. I talked about the large increase in commercial and community fitness centers, even in rural locations. There are communities across the Dakotas that are very small that have these 24-hour fitness places. A place to go. Our community frequently has a $10 a month promotion to get new members. Patients don't worry about what everybody else is thinking at the fitness. They're not looking at you, paying attention to what you're doing. They're wrapped up in their own thing. So I encourage people to know what's in their community and what's available. And I think about that too. I think it's important for me to know what's available in these communities. Well, know what kind of things are in a healthy community. East Grand Forks, they built the flood control project in the 2000s. They did a massive park and trail system, which significantly increased our standing as a healthy community. We have dozens of miles of bike, hike, run, cross-country ski, and snowshoe trails now. So if somebody tells me they don't have anything to do in the winter, I point to them that other than the cost of equipment, these things are free and a beautiful system. Patients can really enjoy some recreation and healthy lifestyle. So be sure that you're aware of what resources are available like this in your community. And sometimes there are promotions. For example, Grand Forks Parks Department does a free cross-country ski day every February so people can try out who may not have done that before. Close with our conclusions. Remember that guideline-based management and prevention is the key, most evidence-based. This includes traditional office-based services, members of the team to their full ability. Make sure that everybody in your team is being used appropriately and in ways that are going to benefit in the system. Community-based or other programs that are science-based, like the Diabetes Prevention Program, can really help patients achieve and manage lifestyle goals more readily as well. And that's all I have for today. So I thank you for joining us, and I would be happy to answer any questions at this time.
Okay, this is Mark. I'm going to go ahead and take the phones off mute. The phones have been taken off mute. If anybody has any questions, please proceed.
Dr. Johnson, this is Stacy. I know some of our states and clinics have used the Stanford model and the DEEP model. Are you familiar with those? And can you tell us a little bit about your experience with them, if you have any?
Yeah, I do know these models, Stacy. Thanks for bringing that up. Of course, these are a little bit more custom models that were developed kind of parallel to some of these other ones, particularly the national community-based programs. Anything that focuses on kind of this magic number of 150 minutes or so of activity that's structured and focused, along with a 7% weight loss or so, are the ones that really have the evidence strongly behind them. And of course, there are many other programs like this that do. 7% weight loss. I think that 7% weight loss key is really important for our patients, because sometimes they have this mythical idea that they have to lose 50 pounds to have any benefit. And 7% is known to reduce their risk of diabetes substantially.
Dr. This is Denise Kolba, and I'm from South Dakota, and we do the Stanford model here. One of the issues that we have discussed is that providers who refer their patients to these self-management education are interested in some feedback and really trying to understand if their patients participated and all of that, so that they can further support them in utilizing these resources. We haven't been able to really overcome that with some of the HIPAA issues and things like that. Do you get and receive feedback from these work groups or from your patients? Have you figured out a good methodology for you as a provider to understand how they're utilizing these community resources that you're referring them to?
Mostly it's feedback from the patients themselves. Of course, I make a note that we've done this so that I know that they've gone there. And often, if I've made that referral for somebody, I actually want to get medical home or the nurse-driven follow-up activated. That, say, our medical home nurse can be calling that patient and asking them how their progress has been. That can be a very useful way to overcome that. Occasionally, we'll have patients that will sign a release so that we can get a letter from the program. So, there's ways to kind of work around some of that. But having some phone follow-up with the patient is probably a good way to do that, if that's part of your system. And most healthcare systems or third-party payers have these medical home systems in place that are very simple referral as well. Yeah, good question. Thank you.
Questions for Dr. Johnson at this time? Johnson, if nobody has any questions or they're kind of afraid to ask here, feeling on the spot, is there a way they can follow up with you or Stacy to get their questions to you?
Yes, absolutely. And please feel free, Stacy, to provide my email to anybody who inquires about it. I'd be happy to answer questions that way as well.
Thank you.
Well, so much, everybody. I appreciate you joining now a couple of different weeks with me. I hope you found this to be worthwhile, and I'll be looking forward to hearing from you.
Thank you, Dr. Johnson. We appreciate you sharing your insights with us. And just as a reminder, the next webinar in the series is called Unexpected Expertise, and that's at 12:15 on May 23rd. There's also additional information, tools, and resources specific to the Diabetes Initiative at the Great Plains Quality Innovation Network, if you to check out that resource. We appreciate and value your time, so please take a moment to complete the webinar evaluation that will appear when you exit the system. Thank you, everyone, and enjoy your day.
Thank you. Have a good day.